There she is. Good afternoon, everyone. Welcome to today's prep webinar. Today's webinar is environmental modifications and attention shaping as methods to improve functioning in people with chronic schizophrenia. Our presenter today is Dr. Stephen Silverstein from the University of Rochester Medical Center. And I will be telling you a little bit more about Dr. Silverstein in a minute. But before we get started, we have a very special presentation today. We want to uh, let you guys know about the second annual IPPER Award winner. So this award, as you guys know, is about celebrating the most innovative programs that embody the goals, values, and principles of psychiatric rehabilitation and in adult inpatient settings. And we've had we had a lot of submissions come in, and we were able to narrow it down to three finalists who are the finalist one was the functional rehabilitation education experience or the free program from the Department of State Hospitals in California. And our second finalist was the Oasis Room, or the Sensory Room Chapel from Anne Klein Forensic Center in New Jersey. And our third finalist was the Hearns Acute Rehabilitation Program, or HARP, from Fulton State Hospital in Missouri. And we had over 1,300 votes come in. And your winner, the winner of the second annual IPPER Award is the Oasis Room from Anne Klein Forensic Center. And we have Sandy Everett with us today. Sandy is a principal occupational therapist at Anne Klein Forensic Center in New Jersey. And Sandy's going to be coming back in April to do a full prep webinar on her own. But I wanted to give Sandy a few minutes today before we started with the webinar to say a few words and accept her award. So, Sandy, I'm going to turn it over to you.
Thank you so much, everybody. I got the award right here. It came so quickly within a second. Um, so I really do appreciate the support of the whole sensory modulation initiative that started back in 2018, 2019. This was not an easy project. It took many, many years because developing a sensory room in a maximum security forensic hospital with people who are a danger to themselves and others was no easy feat. Um, every single item had to be approved, from a little stress ball that could possibly be ingested to a little LED candle so that patients can do some meditation. So everything in this space was intentional. It took a lot of hard work with the cooperation of committees like the safety committee at our hospital, administration, as well as the advocacy of our department heads, my supervisor, Richard Buckwalter, and director of rehab, both Mary Rose Milsarek, both of which are occupational therapists. So this was definitely a team effort to get the patients here an experience of healing that is both body and soul. And I really appreciate the work of the chaplains as well, who helped us develop this chapel space. We don't have a chapel until now we do. It's a pop-up chapel in this space that is really special for patients to engage their soul as well as their body in their psychiatric healing journey. So I'm really excited for this win for Anne Klein Forensic Center, the Oasis Room, and all those who voted.
Thank you so much, Sandy. And we're really looking forward to your presentation in April to learn a little bit more in depth about your program. But we had a lot of votes come in. Surprisingly, we had a lot of votes from New Jersey and California and Missouri. But we did have votes from all over, and we really appreciate everyone who took the time to read about the programs. If you want to read a little bit more about the programs that were finalists, they're still up on our website, on the IPR website. And we really appreciate everyone coming out to vote. And it's really important to recognize all the good work that people are doing around the country. And, it's really interesting to learn about, what other states, what other facilities, what other programs are doing as ways to get ideas for the work that we do. I do want to add that the HARP program, one of the finalists, will be presenting later on in the year. So stay tuned for that, and hopefully we'll get the program from California, the free program, to present a webinar as well. So thank you, Sandy, for taking the time to come and and accept your award. We're very honored to present it to you, and it came so fast. I'm so happy you had your plaque available to you. But we will see you again in April. So thank you so much.
Thank you.
All right. So Dr. Silverstein, would you please share those slides? And I'm just going to get the webinar started. Thank you, Sandy. Okay, so as we're getting our slides set up, thank you very much. I skipped right over our introductions. I am Jen Sperduto, as you might know if you've been here before, and I'm joined by my partner today, Dr. Crystal Socha. So, Crystal, if you say hi, your thing will light up and people can see you.
Hello, everyone. Nice.
There's Crystal. Okay, thank you. So we are from the Rutgers Department of Psychiatric Rehabilitation and Counseling Professions and the Institute for Inpatient Psychiatric Rehabilitation. Um, and our presentation today is sponsored by the Division of Mental Health and Addiction Services through the Department of Human Services and the New Jersey Department of Health and the Rutgers Institute for Inpatient Psychiatric Rehabilitation. Next slide, please. So if you've been here before, you know this is an interactive training. We encourage you to ask questions and participate throughout the session in the chat box. You see you don't have microphones, but Crystal and I will be manning the chat and keeping track of any questions that come in. We have a pretty big turnout today, so we're going to probably hold the questions until the end unless something really urgent and timely comes through. And as always, there's a training evaluation that we'll post at the end of the session today that will have the handouts. It'll have training materials. Dr. Silverstein provided a manual and lots of articles that you have that will be available to you to download or save, and a certificate of attendance. And as always, a recording of this webinar will be available tomorrow on the Rutgers IPR website. And Dr. Socha just dropped a link for that. And so you can access that by tomorrow morning. Next slide, please. And a quick disclaimer, the Psych Rehab Educational Program, or PrEP, is an online forum for a variety of topics that are relevant to inpatient psychiatric hospital staff. And while Rutgers and DBHS and DMHAS are co-sponsors of the program, the PrEP webinars are peer presented, and as such, the content is independently developed by the presenter each month. So the views and opinions expressed in this program are those of the speakers and don't necessarily reflect the views or positions of any entities they represent. Thank you. Next slide. We are being recorded so that we can offer this in our prep library tomorrow. So just be mindful of that. Next slide. And it is my pleasure to introduce Dr. Steven Silverstein. He is a professor of psychiatry, neuroscience, and ophthalmology at the University of Rochester Medical Center, where he serves as associate chair for research in psychiatry and directs the Center for Retina and Brain, a past president of the Society for Research in Psychopathology, and current president of the Consortium for Vision and Oculomics in Psychiatry. His work focuses on visual system changes and treatments for cognitive and perceptual impairments in serious mental illness. Internationally recognized for his contributions, Dr. Silverstein has authored more than 350 publications and developed innovative interventions for people with or at risk for psychotic disorders, excuse me. His honors include multiple national awards for research, clinical innovation, and teaching. Most recently, the Joseph Zubin Award for Lifetime Achievement in Psychopathology Research. And he also serves on the Scientific Board of Prevent Blindness, contributing to national recommendations addressing mental health needs among people with vision loss. And that's a whole big bio that I really pared down. So there's a lot more, but that was enough for one slide. And we're really happy to have you, Dr. Silverstein, and I'm going to turn it over to you, and you can take it from here. Thank you so much.
All right. Well, thank you, Jennifer. Can you hear me okay?
Yep, you're good.
All right. So I'll be talking today about some work that I and colleagues of mine have done with people with severe attentional disability, basically, who, for the most part, were in state psychiatric hospitals or other long-term inpatient settings, and were really not able to benefit from the typical programming that was offered there, including evidence-based groups like skills training or cognitive remediation, essentially because they either couldn't pay attention or were too distracted by symptoms, etc. So I want to make just a few points to introduce this work. One is there's quite a bit of work now indicating that cognitive impairments and negative symptoms are related to poor real-world functioning in people with schizophrenia and other psychotic disorders. But what's sometimes less recognized is that these issues are highly variable across time and contexts. And some of this work is summarized in this short paper that's one of the handouts. Now, of course, there are interventions focused on these issues, such as medications to improve cognitive functioning, which generally have little to no effect at all in randomized controlled trials for people with psychotic disorders. And then cognitive remediation, which does have more consistent evidence for its effectiveness, generally small to moderate effects. But a problem with a lot of those interventions as well is that the people who have the most severe cognitive impairments don't really benefit from them. And so again, what can we do? We need something else for this population. My suggestion, kind of the philosophy behind this presentation, is rather than viewing these impairments as deficits that are somehow stable over time, it's more useful to think of them as plastic or malleable with context, and especially interpersonal and environmental context, and to address the factors that are getting in the way of optimal performance for people, and to remove those obstacles through systematic interventions. So I want to start out with a couple of case examples of patients I've worked with to just illustrate this. The first one is a person who was in his late 30s at the time, a male, long history of, at the time, what was called undifferentiated schizophrenia, which still is a good summary, I think, of what he looked like. This person rarely socialized or initiated conversation, generally had flat affect, kept to himself. But interestingly, about twice a year, we would take the entire inpatient, and by the way, he was in the state hospital for years. So over several years that I worked there, we would go on these picnics in the summer once or twice. And at these picnics, he would be the chef, basically. He would kind of run the grill, and he'd wear the chef hat and the apron. He'd grill all the burgers and the hot dogs and everything. And people would come over and talk to him, and he'd have really a full range of affect. He would smile, he would speak. And then the first time I saw this, I was really shocked. After everybody ate, he was playing frisbee with other people. But then when we would go back to the hospital, he would resume his kind of isolated, behavior, walking up and down the hall just with a flat expression on his face. And that should have been a clue that there was a lot more that this guy could have been doing if he was in a little more of an enriched environment where people were relating to him more as a person. In the second example, this was someone who at the time was in his early 40s, long history of schizophrenia, paranoid type, again, years of continuous hospitalization in a state hospital with a history of violence. He was also a large man, so people were scared of him. It also often would get angry, generally kept to himself, rarely spoke or interacted. And when forced to is sometimes when he would become quite angry or get violent. At the same time, there was a program, or there is a program in Rochester. It started here, now is nationwide, called ComPeer, which pairs people up with someone with similar interests, basically to do things with. And every few months or so, this person would go with his compeer, essentially on a camping trip for the weekend, a couple of days. And then they come back, and the compeer would say, what a great time they had, and they went hiking and fishing and cooked meals and spoke or whatever. And the patient would say the same thing. But again, once he was back on the unit, which had a very medical orientation, he kind of resumed his kind of socially isolated paranoid presentation. And interestingly, on this unit, at one point, we started a point system and kind of an incentive program with behavior contracts, et cetera. And the prediction was that this patient would experience these changes as restrictions and become more aggressive. And in fact, he became significantly less aggressive and increased his level of participation in groups and was able to do what he had to do. He was able to use this new system to maximize his privileges. So that leads me to a study that I've always liked, that no one's ever heard of, from way back in the 1960s, that I want to mention here as a great example of how changes in the environment can bring out either healthier or more kind of classic patient in the state hospital, in quotes, behavior. This was a study that looked at 3 groups of inpatients for 10 days each. And during each of the 10 days, they would video record and audio record these groups of patients in essentially this big day room in a big state hospital type setting. And what was manipulated was what the room looked like and essentially felt like for 1 hour, for each hour, 4 times a day. So each time during these 10 days, for 1 hour, the room was set up in this recreational format that had tables and chairs, small tables and chairs, cards, games, including like horseshoes and darts. And all the professional staff were wearing street clothes. So it was set up in kind of this informal manner. People were encouraged to do things they liked to do out of the choices that were there. One of the other hours in the day, it was what was called the occupational condition, where it was just one big long table in the room, and they had all these things like scissors and colored papers and stencils for people to make signs. So it was sort of like work, but it wasn't hard work, and people could do whatever they wanted to do. And again, the staff were all wearing street clothes. The third condition was the social condition that had a couch and some comfortable armchairs. So no big table for work, etc. There was music played, there was party decorations, and coffee and cake were served. And again, the staff were in street clothes. And then the fourth condition that was present each day for an hour was the medical condition, where the furniture was taken out of the room and the room was set up like in this picture, like a group therapy type of situation. All the staff wore white, essentially white clothes, like a white jacket. The nurse had a white uniform, and the experimenter had a long white coat. And then the door was locked when the last person entered the room. So that what they were looking at was, how did these different stimulus conditions affect the verbal behavior of the patients, in terms of evidence of thought disorder or bizarre, unusual speech? And how did these conditions differentially affect their motor behavior, things like catatonic behavior or mannerisms or posturing, that type of thing? And this is what some of the data look like here. And essentially, if you look at the left, you see the recreational condition, and these first three are the first group of 10, the second group of 10, and the third group of 10 patients. Very low levels of any type of bizarre verbal response. And then the total, which is this gold, also very low, almost none, no evidence of formal thought disorder or delusional speech in that recreational context. In the occupational context, essentially you had close to zero examples of delusional speech or thought disorder, again, with a total of just about 10 over the several days. In the social condition, again, quite low, with a total, again, of about 10 to 15 maybe. But you see in the medical condition, where it was set up to kind of focus on that these were patients in a hospital, you could see very much higher rates in each of the three groups over those days, and then a total that's about 100 times higher in terms of thought disorder or delusional speech, about 100 times higher than in any of the other conditions. So this was some interesting evidence that the context makes a difference, kind of like these case examples I showed. And the data were quite similar in the physical response condition, the catatonic behavior or mannerisms and posturing. Again, the bizarre type of behavior, motor behavior, was much more pronounced in the medical condition. Okay, so now this study is quite old now. It's 60 years old, literally. But there's quite a bit of evidence like this throughout the years. And this is just some additional evidence. We know that if you work with patients on neuropsychological tests that are thought to be, markers of schizophrenia, things like poor executive functioning or attentional impairment, people with schizophrenia tend to do quite poorly. It's not unusual for them to be 1.5 to 2 or even more standard deviations below the mean. But at the same time, if you offer monetary reward, like, a dime, let's say, for each correct response, then what you find is people are much more engaged and their performance is significantly better than it would normally be. Other types of reward-based interventions have done things like length of conversations among people who rarely spontaneously speak. And more recently, using computerized tests, like, for example, of spatial working memory, where you typically show a dot on a screen and then it would disappear. And then a few seconds later, you ask the person to point to where it was. So it's what's called a spatial working memory test. If you give a test like that, people with schizophrenia tend to perform very poorly, to the point where some people think of that as a biomarker of schizophrenia. On the other hand, if you change the stimulus from a black dot to like a smiley face, or if, let's say, the person taking the test was Korean, you use a Korean letter, then you find that performance gets much, much better, approaching normal. So it's not as if there's this global memory deficit, right? And it's just that a little bit more of an engaging context is needed to bring out what the potential of the person is. So you can see what they actually can do at their best, rather than kind of what they typically do in a very much more sterile situation. And further evidence for this was another study that showed if you simply had a conversation with the patient, before they took the spatial working memory test, performance also improved significantly. So just 5 minutes of kind of recognition, it's like, hey, we're two people here and whatever, rather than, okay, here we are, sit down, and you're now going to take this test, which is going to tell us, in an important way, how your brain isn't working correctly. Then, of course, you get a much more impaired looking set of data. So that leads me to what I'll talk about for the rest of the time here, which is this method of attention shaping, which uses these insights I've mentioned in the last few minutes to essentially work with patients who are essentially the most functionally impaired in state hospital type settings. So again, even too impaired to benefit from what we consider to be evidence-based skills training groups, and to over time get it so their performance looks like other people on the unit. Now you can't, these use reinforcement techniques, but you can't just reinforce, let's say through praise or money or whatever. You can't just wait until someone looks perfect and then reinforce them. And that's where the idea of shaping comes in. So if someone, for example, starts off by typically paying attention for 2 minutes during a 45-minute group, and you want them to pay attention for 40 minutes, you can't wait for them to pay attention for 40 minutes and then reinforce them as the treatment strategy, because it'll never happen, or it'll happen so rarely that you won't really make any headway. So you would have to do something like reinforce 3 minutes of attention. And then when they can do that consistently, you then stop doing that and reinforce only 4 minutes of attention. And so you're gradually moving or shaping the behavior from where they are now to where you want them to be. And so that's essentially what this method is. And when I started doing this, I'll say in a second, show some very simple case study examples. But there had been other people doing this for years in one form or another, and that included Tony Mendito at Fulton State Hospital, who's I know on this Zoom today, Will Spalding and Mary Sullivan and their colleagues at Lincoln Regional Center in Nebraska, and Bob Lieberman and Chuck Wallace and his group at the Camarillo State Hospital affiliated with UCLA. And a lot of this work also came from Gordon Paul's earlier work. So the idea that shaping methods can be used with people with very severe and disabling psychiatric symptoms was not new. And what I tried to do with my colleagues, Tony and Will and others, was to really kind of develop a standardized method to apply this to attentional impairment, so that we could not only have people pay attention better, but that they could learn more, they could participate in groups and learn more and benefit from what the unit has to offer treatment-wise as much as anybody else. So that was really the goal. When I started doing this, I started out with single case studies. We essentially worked with patients that were identified by the nursing and mental health tech staff as unable to benefit from the groups that they were running. Essentially, these were the patients that nobody wanted in their groups because they were either too disruptive, or they fell asleep, or they would leave. And so we started with something very simple, where we just had a few patients in a room and we asked them to work on these tasks that they had some input into. These were things, it would be like Sudoku now, except this was before that was popular. But it was like math problems in a workbook, or English problems, or crossword puzzles, or things that you could do where you could see if the person was doing it and doing it well. We observed people doing this kind of thing without any kind of reinforcement for a while. And then we set a goal for everybody based on how long we thought they could do it for, and how accurate they should be based on how well what they were able to do in the baseline. And then we set it up so that we had essentially a big tray or trays of snacks, which was things that they had asked for, which was mostly like candy with a few fruit and other healthy options we could get from the hospital. And if they met, we would have a goal for like each part of the group every 15 minutes. So if, let's say, one patient's goal was to work for at least 5 minutes straight of getting a certain amount of accuracy in that 15 minutes, then we would bring the tray over and they could pick a snack and then keep going. Eventually, the patients didn't like to have they didn't want to be interrupted. They just said, I'll just get everything at the end. So if they met their, let's say, 10-minute goal 3 times, then they would get, 3 times, 3 snacks at the end. This is an example of kind of a typical outcome. I will say this patient was one of our higher functioning patients, but was still a long-term patient at a state hospital, who normally did not do well in groups or even doing individual activities. But the day of our baseline, Of course, she knew we were observing her, so she was able to work for about 15 minutes total in the hour, which was even longer than usual. But as it went on with the reinforcement, you could see that the amount of minutes that she was actually working and doing things correctly dramatically improved. And after this was over, which was, 3 or 4 months of this every day or 4 times a week, she was able to go into other regular skills training groups and do quite well. And now I want to show our worst case example, which was a person with a pretty notable intellectual disability, also psychotic. And you could see a much more variable performance in this person over time. Nevertheless, you can still see a clear trend upwards. And you could see that he met his accuracy goal most every day. So we did this for a while, and then everybody was able to go back into skills groups and stay in those groups. So for our next project, we thought, well, why don't we just do shaping of attention span or duration of on-task behavior in the skills training groups itself, not have some separate pre-training and then put people in skills training. And we were doing a lot of the UCLA skills training modules and some of the Bill Anthony groups back at the time. So we had a lot of groups that they could have gone into. So this next project was about integrating shaping procedures into skills training groups. What we did was for each patient, we had a specific goal, one goal about some type of behavior related to attentiveness and participation. So for this patient who I'm showing here, the goal was to give spontaneous and relevant verbalizations. This was a patient who almost never spoke in group, and if we would ever call on him and ask him to say something, almost invariably his comment was completely unrelated to anything that was going on, often bizarre. But you could see that once we reinforced this, and he knew that, for example, he was expected to give at least one response on his own that was relevant. And then once he was able to do that for a couple of groups in a row, we would make it 2 and then 3. And every 15 minutes, again, we would have someone rating how each person was doing on their goal. So that we would stop the group, ask the rater to say how each person did. And for each person who met their goal during that 15 minutes, they would get the reward, which was either a snack or a small amount of money in some cases. And you can see here, this person became quite participatory in the group. Again, to show another example that was much more challenging, the other example was more typical, but we had a patient with severe negative symptoms who often either would get up and leave the group, or he would have his eyes closed and put his head down and fall asleep. So for him, we had the goal of keeping his eyes open for more and more of the group. And you can see in the baseline, he did pretty well the first day when we had the rater, but then went back to his baseline of, about 10 to 15% of the time, his eyes would be open. The rest of the time they'd be closed, or we couldn't see them because his head was on the table. Using the first intervention where we would reward him like everyone else every 15 minutes, essentially that led to no change. And that's the period in between this line here and the second line. And so for him, we really had to go to a continuous reinforcement where every time he opened his eyes, we literally would give him a snack, which was like one little piece of candy that he wanted, I think was M&Ms. And I remember being very skeptical, thinking, well, he'll just keep opening and closing his eyes to get more snacks, but the total percentage of eyes open time won't change that much. But in fact, he did keep his eyes open more and more. And after a number of weeks, he had his eyes open the majority of the time in the group. Again, not every group, but the overall trend was clearly upward. And so that showed us that sometimes you have to modify these interventions as you go along, but that even with someone who, again, would not be able to benefit at all from a typical skills training group, you could get him to the point where he could. So we then did our first randomized controlled trial of this attention shaping procedures, ASP intervention. And essentially what we did was we asked staff, the nurses and the mental health techs, again, this was in a different hospital now. We asked them to identify, using a questionnaire, which patients were the most distractible and least involved or engaged in groups. And then we chose the ones who were the most, essentially scored the lowest on those. And we randomly assigned everybody, all of them, I should say, to the community reentry program, one of the shorter UCLA skills training modules. And then half the people had only the community reentry program, and the other half, randomly assigned, had right before that this short type of cognitive intervention called cognitive, what is it? Attention process training, APT. And then had attention shaping during the group. And the other half of the patients only had community reentry. And essentially what we found in this initial study was that the group that had, these groups were equal at the baseline. The group that had attention process training had a slight increase. Now, at the time that we started the community reentry module, which was 16 sessions long, but by the end of it, so that was only about 6 weeks later, maybe, they had improved to on a median of 19 minutes of consecutive attention as rated by a non-interactive rater. That was sort of, again, the median, whereas the other group didn't improve at all. They stayed at about 3 minutes. So this was some evidence that we could do attention shaping in a skills training group. And in this project, we didn't have such individualized goals as we did in that prior study. Everybody's goal was expressed in terms of meeting attentiveness criteria for a certain amount of time that was individualized, and not meeting any inattentive or participation interfering behaviors. So I'll get into that in more detail now. So after that, me, along with Tony Mendito and Will Spalding and some others I was working with. At this point, I was at Weill Cornell Medical Center and then moved to Rutgers. We developed a standardized intervention, which is now a 50-page manual with a lot of information and charts and rating forms and fidelity scales for therapists and all kinds of information. And this most recent version is from 2012, version 8. That's one of the handouts also. So everything I'm going to say here is much described in more detail in handouts that you'll have. I want to just go over here the basic features of shaping. Essentially, we define at the beginning of each group what attentiveness means and participating means, and what inattentiveness means. And we also say for each patient what their goal is in this group. We do this all at the beginning of every skills training group session where we're using shaping. We also have a non-interactive rater, and who you need for research studies, so they can really just kind of focus in on, if you have 6 patients, for example, in the group, they can look at each patient for 10 seconds in the group and then switch to the next patient. So you're getting a time sampling of each minute for each patient. What we would do is we would run a couple of group sessions. We would have, through the observational ratings, we would get a sense of how long would the person, how many times, how many minutes would each patient meet the criteria for paying attention during the group. And then based on the average of those first 2 sessions, we set that as the goal for the first shaping session, which was starting in the 3rd session. And again, we review them at the beginning of each group. And the goal consists of 2 parts: a sub-target, meaning the duration of time they have to pay attention for. So for example, 2 minutes or 3 minutes, up to 10 minutes. And then the class target, which is how many times they had to meet the sub-target. So in other words, someone's goal would be expressed as, let's say, paying attention for 5 straight minutes, in other words, meeting criteria over 5 straight observations of meeting attentiveness criteria, and doing that 3 different times during the group. Instead of having a therapist and a co-therapist, we essentially converted the co-therapist into what we call the change agent. This comes from Gordon Paul's work again. So that person whose role was essentially to observe the patients and interact with them around how they're doing around their attentiveness goals. So they weren't really a co-therapist. So they would know what each patient's sub-target and class target were, and they would be prompting patients to pay attention and meet those goals. If the patient did not pay attention or was inattentive, they would prompt them to get back on task, and I'll say more about that in a minute. So they were kind of floating around, not in front of the main therapist, more like in between patients, behind them or off to the side. And their job was to kind of be prompting people throughout the group. When I was first applying for grants for this, a common criticism was you're doing things to distract the patients and you're going to make them worse. But actually, after the first session or so, everyone gets so used to this that they actually want the praise and the interaction, but it's very brief and quiet. It does not interrupt the group. And then you have to have some type of rewards for people who meet their class targets. In the best case scenarios, you can ask people what do they want those goals to be, which we've done, and it's usually things like coffee or certain kinds of snacks or increased privileges on the unit or to leave the unit, etc., and sometimes money. Patients who meet their class target get their reward, and patients who don't get feedback on what specific behaviors they could change to meet the goal in the next session. Patients who meet their goals 2 sessions in a row get a higher goal for the next time, and if a person doesn't meet their goal 2 times in a row, they go down. And we had a pre-specified kind of sequence of attention targets. So to go into a little more detail on some of this, the attentiveness criteria that we used were here. Here it's really boring, but we had it on a nice big laminated chart with some colors and nice symbols and things like that. But the point is they were very clear. Paying attention means your head's up, your eyes are open, and you're looking at what's happening, the focus of the group, and that you're occasionally participating. If you're called on, you give a relevant response within 5 seconds. That's on topic. If you're asked a question, you say more than 1 word or more than 2 words, etc. And then we had at the bottom what not paying attention means, so things not to do. And each time a person met their sub-target, again, we would hand them a shaping ticket. The change agent would hand them a shaping ticket and say something like, great job, Joe. You just paid attention for 3 minutes, which is your sub-target, so you get a shaping ticket. If you can do that 2 more times during the group today, you'll meet your class goal. Okay, so and we reviewed this again, every single group, often calling on one of the patients to review it and making sure that everyone understood what their goal was in the group. We had a pre-specified sequence, starting with literally paying attention for 30 seconds 1 time in the group, going up to paying attention for 10 minutes 4 times for 40 minutes. And these were normally like 50-minute groups. I will say that any of us here, if you got 6 of us together in a room, no one would be coded in the system as paying attention for 50 straight minutes. Everybody sometimes looks out the window or looks at their phone or whatever. So 4 times for 10 minutes was quite a high goal. So the question is, what happened if someone didn't pay attention? What if they did look out the window or started talking to themselves or whatever? We always use this specific intervention, which is simple yet important. So the first time something happened, the change agent would specify what the behavior was that was inattentive and what the consequence was. For example, Jim, you're talking out loud about things that aren't related to the discussion here. If you keep doing that, you won't be able to earn your next shaping ticket. So that's the negative prompt, but it's quite specific to the behavior. The positive prompt is then, but if you can get back involved with our discussion, you'll be able to earn your next ticket and make progress towards meeting your class target. So this would happen the first time an inattentive behavior was observed. And importantly, if the behavior continued after the prompt, unless it was totally disruptive to the group or caused a safety issue, we would continue to ignore the behavior. And only when the person did get back on task, so again, looked up at the group therapist, for example, would then the change agent approach them again and say something like, Joe, great job, looking up at the speaker again. So now, if you can do that for 3 more minutes, you'll get your next shaping ticket, etc. The point was to have most of the social and symbolic reinforcement here through the shaping tickets, which were worth real things at the end of the group, but to have most of the reinforcement be for appropriate attentive behavior. We did not want to have most of the comments to patients being about their inattentive behavior, which is much more typical of what happens on like a state hospital unit, for example. And so the prompt sequence was quite simple, but the effect of doing this way was quite powerful. Okay, so we then took our manual and did another randomized controlled trial, collecting data at Cornell Medical Center, Nebraska, and Fulton State Hospital. This time, people were in the UCLA Basic Conversation Skills module, which is a much longer intervention than the community reentry program. So it takes several months, usually 3 to 4 months to get through it, doing it twice, 3 times a week. The main finding from the study is here. And you can see that compared to the baseline 2 sessions of observation, the number of minutes that people were coded as paying attention went up dramatically from in the attention shaping group, from about 15, 16 minutes to about 25 minutes. And in the control group, it had a non-significant effect. And the effect size was much larger when we actually did a slope through the attentiveness each of the days. This graph just shows comparing the first 2 and the last 2 sessions. The effect size was D equals 1.51 of that. So it was quite a large effect. We also showed that not only was the total minutes of attentiveness improved, but the amount of time that people continuously paid attention for before they would break off from that also improved. And that's shown here, going from 3 minutes to over 6 minutes compared to 3 minutes to about less than 3.5 minutes in the control group. We also showed that the attention shaping group showed a significant increase in learning of material taught in the skills group using a standardized measure for social skills and knowledge developed specifically to assess this basic conversation skill module. This graph shows the change relative to baseline, and you can see on the left the attention shaping group, the control group on the right. So there was about a 30% greater ability to demonstrate social skills appropriately in role plays, and an improvement also in knowledge of what to do in different situations in the shaping group compared to the control group. And importantly, the amount of improvement in social skills was directly related to the amount of improvement in attentiveness. It's kind of hard to see these axes, but essentially the x-axis is showing the improvement in attentiveness over time, and the y-axis is showing the degree of improvement in social skills. And there's a nice positive relationship there. One of the comments I'd often get when we were first presenting this work was, well, maybe it's just that the longer the patient's on the unit, the better their medication is. And that's what's causing the effect. Of course, that doesn't explain why there's a greater effect in the shaping group than the control group. But we actually then looked at what was the chlorpromazine equivalent medication dose on each day, and how did that correlate with the amount of attentiveness each day. And I was happy to find that the correlations in both groups were close to 0. So really, it was the attention shaping that was doing the driving the effect, not any medication changes. So the last study we did of this was in a partial hospital program. We wanted to see, would we get similar effects outside of an inpatient unit? So we again used the basic conversation skill module with or without attention shaping, had over 40 people in the group. And we looked at not only attentiveness improvement, but also changes on a cognitive battery, the matrix battery, symptom change, and did they improve their social functioning as rated by an informant? And in other groups in the program that didn't use shaping, which was every single group except for the one that we used it in, would they show increases? Would the group that had shaping show increases in non-study groups more than people who are in the control study groups? And another thing we did here is we would give rewards to people in the non-shaping group just to make sure everybody was matched. The groups were matched on how much reinforcement was given out. We wanted to make sure that the effect wasn't simply due to reinforcement. So what we did was, for example, if we had 4 out of the 6 patients meet their class target in the shaping group, we would randomly give 4 patients in the control group in the next session reinforcement. And we would say something at the end like, this is part of a research study, and as part of that, we have to randomly give money or candy or whatever it was to a certain number of people each group. And today, randomly, we chose, and we just then named the people and gave them the reward. Basically, here we found the same thing as we did in the other group. There was a significant improvement in the total minutes of attentiveness in the shaping condition, and it actually went down in the control group. Same thing in non-study groups. It was a much smaller effect, but it showed that this generalized to some extent. Now, it only generalized by a few minutes, but what this said to me was if we were using shaping in more groups with these patients who were quite the most attentionally impaired of anyone in the program, we would have even larger effects. Some other findings were that the attention shaping group actually improved their scores on the matrix cognitive battery, which I don't think is because we were improving any kind of circuitry related to cognition specifically, but I think we were showing people that, or they were experiencing themselves as being able to persist a test longer and succeed, which was a major thing, a major improvement for them or aspect of their treatment. So they persisted longer and did better on these types of tasks. And the patients in shaping group also had more reduced scores on the positive and negative syndrome scale, a general symptoms factor, cognitive and depression factor. And of the people in the shaping group, the ones who responded the most, let's say the group that responded the strongest, also demonstrated greater learning of conversation skills, greater social problem solving on the assessment of interpersonal problem solving, greater social functioning as rated by informants, greater change in score on the ups of the functional assessment scale, a greater drop in negative symptoms, and a greater drop in self-reported cognitive difficulties. So it was quite successful. And I want to end by going back to a case study. This one is not one that I was involved with, but I just want to make the point here that I've been showing data from state hospitals and partial hospital programs, but this could be done in any type of setting. And this was from the Boston group, Psych Rehab Journal, back in 2000. They worked with a patient who was in essentially a group home setting who used to like to read, but now didn't like it anymore because he was so distractible that he would read like one page and then have to read it again. And it became something that was unpleasant for him. So they worked out essentially he and a staff member, like a single plan just for him for reading, and that he could reward himself with certain foods that they would buy as a reward, but he could only eat them if he met the goal. And you can see here across several conditions where the shaping criterion changed that he was able to get up to about 8 pages at a time by the end after a few weeks. And So that's a pretty big change. And of course, it changed the whole feel of the experience. Now this person was able to do something again that he liked. Okay, so just to wrap this up, cognitive functioning performance can be highly variable across settings, but we can take advantage of that in our treatment. And by this, I mean even level of engagement and effort. There are many factors that determine this, including there has to be opportunities for meaningful activity. Some big studies have shown that level of negative symptoms, for example, on inpatient units is related to how much there actually is to do there. The availability of reinforcement, including staff understanding that they can provide teaching and social praise and reward for appropriate behaviors. Beliefs about performance, which of course can change as people start to see themselves succeed. Staff behavior has a big influence on whether people kind of perform optimally or kind of revert back to more of a mentally ill presentation, and then many other medical factors. Some of these are reviewed in this, again, very short paper that's in the handouts. And the good news here is that all these factors are modifiable and should be addressed and can be addressed, and that will improve outcomes. And this paper here, which is not in the handout, is just an example of using the technique of shaping for a wide range of behaviors, including, getting up on time and behavior at meals or whatever. And a lot of the work of Tony Mendito and Will Spalding and the UCLA group and back to Gordon Paul, of course, have shown this as well. But it has to be done systematically with staff who are very motivated to do this and who approach patients in a very positive way. So I'd like to thank, there's too many people to thank. I've been doing this for a long time now and had many students who helped, people who taught this to me, and hospital administrators who made this work possible. So I'll thank them very quickly here. And thank you all for your participation. And I realize we don't have too much time left, but I'd be happy to answer any questions if we have them.
We did have a few questions come in. Thank you so much, Dr. Silverstein. I'm going to hand it over to Crystal for the Q&A part.
Yes, thank you again for the presentation. There were a few questions that came in, and as you were talking, kind of answered some of them. So we'll preface with that. One of the questions was, I assume patients were under medications, antipsychotics plus others, any correlations with their behavioral response? And I know that after this question was asked, you had shared a little bit about the attention shaping that drove the effect, not the medications. Could you speak more to that regarding the medications?
Yeah, we looked at this in several studies. We never found that the amount that people's attention could improve or the amount of learning that improved as a result of attention improving, that was ever related to medication dose. I also want to say that for a lot of patients in state hospitals, they're very over medicated. A lot of these patients were on multiple medications. And to quote someone who will remain nameless, but a very good psychiatrist, if you read Gordon Paul's work, for example, you see that the patients who were treated in these social learning programs typically were discharged on far less medication than people on other units, and with much better outcomes and longer community tenure. Because essentially these were people, in the 30% of people with schizophrenia who are not responsive to medication. But what typically happens is they're just given more and more medications because nothing's working. So I once said to a psychiatrist, why don't we take people off the medication? They're clearly not responding to it. And then, which, have anticholinergic effects that are impairing memory and they're sedating. And we'll see, maybe we could even get greater effects. And he said, he knows it's the right thing to do, but if he does that, the nurses will kill him. So it never happened. And that, unfortunately, is quite typical. So, clearly these are not due to medication effects. Of course, if someone is optimally medicated, and Tony Mendito has shown in a paper that, for example, people being switched to clozapine who improve and then are also in these types of interventions can improve even more. So yes, if someone's medicated appropriately, but often they're not. And so that's why it's hard to show a link in general with medication and effects.
Thank you for that. I know we're just at our time. Jen, go
Crystal,
ahead.
I know we don't normally do this, but because we had the IPER award presentation, we can go till 4:05 today, but then we have a hard stop. So we have a couple more minutes for the extra questions that came in.
Okay. The next question, how does internal versus external motivations impact the approach of attention shaping?
Yeah, that's a great question. I wrote an entire review paper about that that is in Schizophrenia Bulletin in 2010. I can't recall if that was one of the handouts or not, but if it wasn't, please email me and I'll be happy to send this paper to anybody. The gist of the answer is that attention shaping works great for people who essentially are, very disorganized, have severe negative symptoms or such severe positive symptoms that they're inattentive, who are not going to engage in something if you need intrinsic motivation to engage in the task. But once people essentially believe that they can do something and are able to persist in the task for a while, then the extrinsic reinforcers become less and less important. And in fact, you want to fade them and stop using them and rely only on social reinforcement and on intrinsic reinforcement. And there's a lot of literature in severe mental illness and autism and other populations that shows that. So I've been having this running debate with Alice Medaglia for like 35 years now. Very friendly debate, but that's really the way it is. In most outpatient settings, I would not want to use attention shaping. On the other hand, I've tried to use like the NEAR model with the most impaired patients in state hospital settings, and it can work sometimes, but generally you need to get people almost socialized to a group setting and then starting to have a new vision of themselves that they actually can participate in these things and do well. And the extrinsic reinforcers really play a major role in that.
Thank you. The next question, how is a person's choice incorporated with this approach?
It's hard when someone's in a state hospital involuntarily, which is often the case. We try to incorporate choice by choosing goals, sometimes letting the patient assist in choosing what their goal might be. In the earlier demonstrations, we had patients choose what the reinforcers would be, what would be most meaningful to them. But no matter how I try to spin it here, and I realize I don't have time to even try to do that, which I never do anyway, but choice is limited in these behavioral interventions for people who essentially don't seem to benefit from any other type of intervention. I just really want to stress that. You're dealing with very disorganized people who generally don't contribute to their own treatment plan in a meaningful way at first. The goal is to get them to the point where their behavior changes enough where they can do that. So Fred Fries, who unfortunately died a few years ago and was a person with lived experience of psychotic disorder and was a great advocate for many years at APA and elsewhere. He wrote a great paper on this very issue, essentially how when people are at their most impaired for a long time and nothing seems to be working, sometimes it can't be like working with a client. It is more like you're using technology. And as they are able to then express their needs in a non-psychotic way and participate more, then of course you want to maximize the degree to which their choices drive and preferences, drive the treatment planning. So I'm all for that. But it does vary based on the level of disability.
Okay,
Great.
well, thank you for answering that. I'm going to end it here, Crystal, just because I need to do a little bit of a wrap up. Dr. Silverstein, thank you so much for such an informative presentation. You all have, if anyone's still around at 4:05, thank you for sticking around. Everyone has access to the manual, the slides, the handouts, and the articles that Dr. Silverstein talked about. And if you don't get to do the training evaluation today, we send a follow-up email tomorrow morning that gives you all of that information. And you also will get the link to the page with all of with the recording for this prep webinar, and all of the ones prior to that. So you'll have access to the entire prep library. So thank you all for sticking around an extra 5 minutes because we thought that was important to get those couple questions in. And Dr. Silverstein, thank you so much for being with us today. Everyone, the next presentation, our March prep, is on St. Patrick's Day, easy to remember. So be on the lookout for some, shamrocky uh, information for March's prep webinar. So thank you all so much, and we'll see you next month. Take care.
Bye, everybody.